Herein may lie the most difficult step in the decision-making process for a counselor who is in recovery and treating a newly recovering addict, either individually or in a group setting. Therapists and counselors are human beings and as such have feelings. These feelings might affect clinical judgment and reasoning with regard to setting boundaries so as to avoid the dual relationship. This is not to say that therapists and counselors cannot be genuine. Genuineness does not imply a high degree of self-disclosure, but a genuine presence in the therapeutic relationship. To paraphrase White, 2006, the use of self, using one's own personal and cultural experience to enhance the quality of service, has changed dramatically over the past 4 decades. In the paraprofessional era of addiction counseling in the early 1950s to early 1970s, disclosing one's status as a recovering person and using selected details of one's personal addiction and recovery history as a teaching intervention were among the most prominent counselor interventions. This dimension of the counselor role was based in great part on the role these dimensions played in successful sponsorship within Alcoholics Anonymous through the 1980s and 1990s. In present-day professional alcohol and substance abuse counseling, such self-disclosure has come to be seen as unprofessional and a sign of poor boundary management. Who will be affected? Both parties. Okay? So, with the differentiation, the patient sees you as this highly skilled, highly trained, highly educated, highly experienced professional person up there who can treat, who can help them. And based on the motivational interview, what we said, I can help you with that. They see there's an alliance there. I can help you with that. So if you self-disclose and there's a change in the differentiation where the patient starts to relate to you, if you come down, this patient starts to relate to you as a peer, that affects the patient in a not great way. Okay? So therefore, based on that formula, you cannot self-disclose that you are also in recovery. Because it will affect the patient in a not a good way. Okay? Because it will lower your professionalism. Okay? Follow me on this. Follow me on this now. Okay? Adopt the perspective of your client. Notes on this are, from the client's perspective, this writer would rather have their counselor in the role of a highly trained and highly educated professional. The client needs to see their counselor as a professional individual who has the knowledge and ability to help them recover. As the client, this writer would not wish to relate to their counselor as a peer and thereby damage the therapeutic relationship. Upon careful review of this decision-making process, this writer, me, would be very comfortable in making a decision not to self-disclose, and I would. I would be very comfortable making the decision if the situation was that I was in recovery, or whatever it was. Whatever it was. Whatever their issue is, I can help them with it, whether I've been there or not. The research shows that counselor self-disclosure is not an effective therapeutic technique to aid the client to be more open and forthcoming. peer support and the peer relationship and peer support is a very healthy relationship to have in recovery, okay? And that peer support of relating to someone as a peer and their shared recovery exists and is very, very strong in 12-step programs, okay? So, to have that relationship, you don't want to have that relationship with the patient. You are in the client-patient relationship. They need to have that relationship in one of the 12-step programs as support of their recovery, okay? So we have to differentiate our professionalism between treatment and 12 steps. So I strongly encourage patients to attend 12-step programs. And like we said, not just this or that, everything. Therapy, counseling, prevention, doctoral, medication-assisted treatment like that. But that is a strong component, and it's healthy and working very, very well in 12-step programs.
I have self-disclosed to clients by saying, but they don't know that I'm self-disclosing. You know, I had a client once with the supervision, or I had a client once who struggled with something very similar to
Yes.
I didn't have that client. I might have been that client.
No, you
don't
never
know
should.
that.
You've done what
That's
yourself.
not self-disclosure.
Well,
Yeah.
it is in a way.
No. You can give first-hand information,
Secondhand.
second-hand,
Right.
from a second-hand perspective, like that has happened,
Right.
or you know, this is how this person overcame that, but it's really you. But you're not telling them it's you. That's okay. There's nothing wrong with that. You want to use all your tools that you have as a therapist, as a counselor.
Right.
You want to use that, and if that's a tool that you know what they went through and that's what was needed in that situation, because that was something that existed right now in that moment, then you could say that in the third person. That's okay. That's one of your tools.
But yeah, I tell the clients, listen, you don't have the corner market on abandonment, rejection, and stuff. People deal with that. Your problem is when you deal with that, you can't stop.
Right.
They can.
That's good.
Yeah. But you're not unique that you're suffering from this. Everybody has abandonment, rejection,
Yes.
issues and stuff
Yeah.
that have been hurt.
When you're in it, you think you're the only one that's in it.
Right.
You're not. There's plenty of other.
And
That's
then-
why group therapy is great. That's why I
Right.
love running group. Because the people that come to treatment, you know, we understand like that. You put them in a group and you get them in another couple of
Yeah.
weeks. You're not everybody understands it. I went to that last Thursday.
Yeah, you're not unique.
But that's also sort of self-disclosing too, because you're saying, well, if everybody has abandonment issues, you're saying, I'm part of everybody, so. that's-
Others,
Other people.
not every, not critical things
Many
don't
people.
overgeneralize. So you couldn't have.
Well, a lot of times I'll tell them I work with people down on addicts that have the same issues you have.
That's good. That's a good one. Yeah. Because I work with people who are on acid, just, you know, cognitive behavioral psychotherapy, they're doing something else, some other issue, you know, there are other issues that people have. Does that answer your question, Pete? Okay, so. I just want to get something else, as part of that, on there. That, you know you've made it in the publishing field when someone writes an article about your article. So, as far as full disclosure goes, I've included that in the printed handouts, okay? Now, they wrote an article about my article, and they are, you know, you can read it and see, because they originally take the position, because if you look at them, you know, there's a couple of guys that have been around a long time, and I challenged them, you know, this was a challenging article, just like this is challenging. But you see, as you read into it, they actually are agreeing with me. They're in their own way to say, well, you know, where I'm saying not at all, and that's not just me, there's other clinical supervisors, and I can name several, that's the policy of the program. You do not self-disclose, okay? So they're saying, you know, they're saying something else, you know, other than that, but when you read into it, they actually are agreeing. They are agreeing with me, okay? So they may not have intended to do that, but that's my story and I'm sticking to it. And that's included, you know, in the printout and the handouts as far as this presentation goes, okay? All right. I wanted to include this information regarding peer support that we have been discussing a couple of slides back. The first one is the application for the Certified Addiction Recovery Coach. And then the second one is the application for the Certified Recovery Peer Advocate, which is a more advanced certification. Certified Addiction Recovery Coach just requires certain recovery coach training and, of course, a fee, but there's no exam. The Recovery Peer Advocate certification requires some additional hours of training, and you have to take a test. Pass the test, and of course, also there's an application fee. But the Certified Recovery Peer Advocate, if that individual is working in an OASAS licensed program, when the CRPA sits with a client, that is actually insurance reimbursable. Now, these are both non-clinical positions, so they aren't part of the multidisciplinary clinical treatment team, and that the CASACs are the clinicians that do the treatment. So the recommendation is that CASACs do not get the recovery coach certification or the recovery peer advocate. That's a separate non-clinical certification that individuals can get to do peer support and peer advocacy, and that CASACs and then the other QHPs can actually do the treatment. And it looks like it's going to work out very well. So I just wanted to make sure that I did some follow-up and provide some information about peer support.